1 second, it goes. And then I will open the webinar session. Excellent. People are joining. Let's wait for a few more, maybe not minutes, 20 seconds, and we will begin. Can you hear me well? Okay, excellent. Welcome to the Accreditation Canada webinar. I'm Kirill Kornilov, International Market Development Manager with Accreditation Canada. I will be the moderator for today's session, and I'm delighted to have you all here today. Today's webinar is dedicated to Emergency Medical Services, EMS. It coincides with the Emergency Preparedness Week, currently taking place in Canada, as well as International Firefighters Day, which was celebrated last Sunday. We're shining a spotlight on a crucial yet often overlooked field. This webinar will showcase the incredible daily efforts of ambulance companies, paramedics, patient transfer services, medical evacuation teams, and both urgent and non-urgent transport providers, including ground air and air transport. And obviously, we'll talk about patients. This webinar is simultaneously interpreted in French, so feel free to choose the language that you prefer. You just need to choose the appropriate channel. This session is the second part of our webinar series focused on EMS. The first webinar took place in the fall last year, you may remember that, and was conducted in French, simultaneously interpreted in English at that time. You can easily access it on our website. We'll share the link in the chat. Before we begin, I'd like to cover a few housekeeping items. If you have comments, feel free to type them in the chat box. If you have questions for the speakers, please put them in the Q&A section, and we'll address them during the Q&A session at the end of the webinar. We will send you all the presentations, the recording of this webinar, and for those who need it, we will send a certificate of attendance. Also, please fill out the survey at the end of the webinar. It will take just a few minutes, but your feedback really matters to us. We have an exciting lineup of international speakers who will be sharing their insights on EMS today. It's my absolute pleasure to introduce today's distinguished panelists. I will be presenting them in the order they will be speaking. Also, an important update. Regretfully, we have just been informed that one of our speakers, Firas Aldalkak, may not be able to join us today. He'll try, but maybe it won't be possible. So I will be introducing the speakers right now, but please, dear speakers, if I miss anything in your introduction, feel free to add to it when you come up to speak. So Heather Thiessen. Currently, Heather serves as a patient partner at HSO and Accreditation Canada, where she supports patient partners across Canada and internationally. She has also been trained as a patient surveyor with Accreditation Canada. Captain Martin Mulkers, trying my Dutch pronunciation, as the EMS manager at Rescue Services Zone North Limburg in Belgium, Martin oversees the coordination and delivery of emergency medical services, ensuring efficient and effective response to medical emergencies in the region. Christopher Fahey, serving as the Accreditation and Logistics Officer at Lethbridge Fire and Emergency Services in Alberta, Canada. Christopher is responsible for maintaining high standards of care and operational efficiency, ensuring the service meets rigorous accreditation requirements. In his presentation today, he'll be exploring the operational mechanisms of medical transport services in Alberta. Michael Longway, as the Director of Clinical Affairs at Orange in Canada, Michael oversees clinical operations and quality improvement initiatives for air ambulance services, ensuring the highest standards of patient care and safety. He'll be presenting the coordination between air ambulances and ground ambulances. And the last speaker, hopefully he will be able to attend, I will still introduce him, and that's Firas Abdelkak. Firas is an EMS advisor at the Ambulance Department of Abu Dhabi Civil Defense Authority in the UAE, where he provides expert guidance on emergency medical services and contributes to the development of advanced EMS protocols. So hopefully he will be presenting today quality management practices in the EMS sector in Abu Dhabi. Without further ado, please join me in welcoming Heather Thiessen, who is going to give a short but very important opening from the people-centered care perspective. Heather.
Thank you, Kirill. Thank you, Kirill. And good day, everyone. My name is Heather Thiessen, and I'm honored to live and enjoy life on Treaty 6 territory, homeland of the Métis, also known as Saskatoon, Saskatchewan. If you looked at a map of Canada, we're smack in the middle. I joined the conversation today as a patient with lived experience, dealing with 3 chronic conditions and years in and out of the hospital, and a user of EMS services, which has allowed me a glimpse into the amazing world of healthcare. I am as well a patient surveyor with Accreditation Canada and a patient partner leader within the engagement team at Accreditation Canada and Health Standards Organization. For the past 18 years, I've had the privilege of being a patient partner, partnering at the local, national, and international level as a patient with lived experiences with many health organizations, seeing what is possible when we bring that lived experience voice of patients and families into healthcare improvement. Being chronically ill, I have learned so much about healthcare land, as I like to call it. It has its own language, please no more acronyms, pathways, and cultures, and it is not often very welcoming to patients. Here at Accreditation Canada and Health Standards, we embed people-centered care philosophy from the World Health Organization into our work, in partnership with and with input from, can be seen woven throughout our world-class standards. We also know that in order to do people-centered care well, we need to engage with those that know firsthand about health systems. Following engagement frameworks like the International Association of Public Participation and the Carmen Framework, to name a few, have been instrumental in helping us to partner in an equitable way. And it never fails for me to see how conversations change for the better when the voice of those experiencing the healthcare system is welcomed, and how we do better together. That is where that nothing about me, without me, about me philosophy can really come to life. People-centered care is the destination for us, and we get there through meaningful engagement. Our HSO standards bring forth many voices of those in the field to contribute to the work, and here as well, we ensure to engage and make sure we have equal space for those with lived experience within our standards. We have designed some educational programs on people-centered care for our Canadian and our international clients. In fact, we try to ensure that we bring that lived experience voice of patients and families as an equal partner into all our work, knowing, again, we are stronger together. Working in a people-centered care doesn't take extra money or effort, but it does take making sure that when conversations are being had, that the voice of patients and families are invited, involved, respected, and valued for the important part that they bring to that conversation. No one knows that story better than those that have experienced the crisis or the condition that is being laid in front of the healthcare team. When I think about today's webinar, focus on EMS medical transportation, ensuring seamless, high-quality pre-hospital care, you will hear from these amazing speakers today on the flow of how to do this. pre-hospital care safely. It is important that we do this well and in a seamless manner, working in a people-centered way. And it really helps us to know that all that will be part of this conversation are hereby that invitation to do that space or to do so. I've been very fortunate to have worked closely with Medavie Health Services West here in Saskatoon for the past 8 years. I have done patient journey mapping with them, and we really learned a lot about the experience of patients, but also about staff. When on a call and at work, we have done some work where those trigger points have, where that communication has broken down. One thing that we have embedded is that with all the new employees to that organization, I come and speak to them about being in a people-centered care culture so that they are learning about it on day one and it can be incorporated into other conversations about how they can work more closely with those who are in their greatest time of need during an EMS call. Relationships are the key when we were thinking about how to start and build this into your work. And it does take time, but in this fast-paced world, time is often not our friend. Partners with health authorities or quality councils who have already established patient partners could be a great link to tap into to get that patient voice and find new ways to partner with them within your organization. Start small, but with any quality improvement work you do, enhances people-centered care. Make sure you have that lived experience voice there and guarantee when you start, it will flourish and you will see amazing results and that you will have better experiences for your future patients and families on your calls. So please enjoy today's presentation and happy to answer any questions at the end of the presentation. Back to you, Carol.
Thank you, Heather. Excellent introduction. Often everything begins with an emergency call to dispatch. In North America, this call goes to 911. While in Europe, the number is 112. Please join me in welcoming our first speaker, who will discuss EMS dispatch management in Belgium. So, Captain Mulkers, the floor is yours. Hang, Martin.
Thank you very much, Kirill. Good morning or good afternoon, everyone. I'm not native English speaking, so I do my best to get a clear presentation here. First of all, I would like to thank Kirill and his team for this invitation. In this part of the webinar, and I try to share my presentation now with you. I hope it's going to come all right. Yes. I hope everybody sees my presentation now. So in this part of the webinar, I hope to learn you a little about the emergency medical system in Belgium. So first of all, let's take a look at our schedule of this presentation. We will start with the legal context about the global healthcare in Belgium and more specific, focused on the emergency medical system in the country. That will bring us smoothly to the next part, the tasks that are reserved and provided by that system in order to help each citizen in an appropriate way. Afterwards, we consider the principles and strategies on which the organization of the EMS is based, and we go over to the different types of resources in the field and conclude with a word about disaster management and crisis handling. So first of all, the legal base. The first legislation of the EMS dates back to 1964 in Belgium. Before this, there was no structured system in Belgium, and the population had to rely on themselves for access to the necessary emergency care, only provided by hospitals in their region at that moment. Some general practitioners were equipped with emergency manuals and were standby for emergency calls, but that was rather an exception. Because the quality of care was too low, the government decided to introduce the first legislation in 1964 regarding on the organization of urgent medical assistance to a citizen in need. The current situation of the system is still based on this old law, but it has been built upon when additional developments occurred. For example, we see additions appearing around the medical intervention plan, which is the name for the medical disaster plan in Belgium, but also a psychosocial assistance plan in the event of major incidents. And finally, a legal text that aims for multidisciplinary integration of emergency services during the major incidents. So let us have a closer look on the complex political situation in Belgium. Belgium is a small country with a surface of 30,000 square kilometers, sorry, and not so small, and a population of 11.7 million citizens. But the country is divided in a few regions, mostly depending on the language that is spoken in different regions. Both the federal and the regional governments have their specific domains and responsibilities, which do not overlap each other. The teams do overlap, but the substantive powers do not. For example, we have 9 ministers of health, but each of them has a different aspect of public health under their area or of responsibility. The country of Belgium is politically divided into 3 regions, namely the Dutch-speaking region, called the Flemish region, then the French and German-speaking part of the country that is called Wallonia, and also about the capital city, Brussels, called Brussels Capital Region. The responsibility of organizing the emergency medical system is assigned to the federal level of government, just like the fire, the rescue, and the police services. Until today, it was not possible to transfer the safety domains to the regional governments. The importance of a national cooperation of the different emergency services could not be guaranteed at the moment of directing the responsibilities to the regions. So that's why they did not manage to transfer it already. In addition, following the attacks on Zaventem Airport and the Brussels subway in 2016, the federal government set up additional structures to increase national security and initiate a national terrorist response plan. So I already told the emergency medical system in Belgium is a federal jurisdiction. Within the system, their partners are determined by approval by the government, and only these actors can provide service in this emergency system. For daily care, there is a fixed number of emergency response units standby, and on the other hand, additional resources can be added in the event of an activation of a disaster emergency plan. If we zoom in on the few tasks concerning the public health assigned to the different regions, we see in addition to elderly care and care institutions for the disabled, also the responsibility of the organization of the non-urgent transport of sick people. Unfortunately, this non-urgent transport is regulated very poorly or almost not at all by the regions. As a result, many calls for non-urgent patient transports end up in the emergency care system, which often leads to an overload of this system. As you can see, the powers within healthcare in Belgium are strongly divided between the different governments. In order for the system to function as integrated as possible, it is very important that all the departments take on their own responsibilities, but also work together. Within the big world of healthcare in the country, EMS is only a small but an important part. Now we will zoom in on the organization of the emergency medical system, starting off with a look at the tasks that are attributed to this kind of care. As mentioned earlier, the organization of EMS falls under the responsibility of the federal government. They have divided the tasks packaged into 3 parts. On the one hand, urgent medical assistance, which we will discuss in detail later in this presentation, and also sanitary safety, which mainly concerns the surveillance of the ports to keep exotic organic material out of the borders, out of the country, like possible tropical pathogens. During the COVID pandemic, this department was also assigned an important role. And thirdly, the psychosocial assistance that must be provided to victims and those involved in large-scale incidents such as crises and disasters. More in detail, the medical chain provides different types of services on the field. The most important is the deployment of the entire emergency medical chain. It's logical that they give urgent medical and psychosocial treatment to the victims or sick people in serious conditions. Relied on this care, they are responsible for transporting victims to the hospitals by ambulance or helicopters. It's written in the law what the regulation possibilities to the hospitals are. It stipulates to which hospital with an emergency department the patient must be transported. In most of the cases, the patient is brought to the nearest emergency department, but in case of a specific pathology requiring a particular medical specialism, the law describes exception of transportation to this nearest hospital, which will be changed to the nearest hospital with the availability of the necessary specialism. Another task of the medical discipline is protecting the public health and taking measures gravity concerns mainly avoiding the spread of infections, biohazard contamination of the population, or measures in case of spread of toxic substances, for example, by building fires or accidents with dangerous substances. In fact, they can give advice to the people for self-care, but can also organize a large-scale evacuation or a mandatory vaccination program. The last big mission of the EMS department is the deployment of critical treatment structures and activation of a lot of medical units in case of a mass victim treatment. They also participate in the multidisciplinary coordination unit of these events. On the strategic level, the federal government is responsible for providing the financial resources to keep the system running. They determine the minimal level of training for the medical actors and make decisions for improvement in quality and efficiency of the EMS system based on data analysis. They also do inspections of the units on the field to check whether they comply with imposed expectations. So with a general view on the EMS missions, we can make a distinction between the daily emergency care, which is based on the treatment of one victim per unit. The EMS partners are permanently available with an activation time of 3 minutes after an emergency call, and they are geographically spread so that the entire territory of Belgium is covered by an intervention time span of 15 minutes for 19% of the incidents. The other type of organization is the handling of major events, crises, or disasters. The basic system, which provides a daily service, will be upgraded with other emergency services like the Belgian Red Cross, private ambulance services, the army, etc. The handling of the event is different than in normal circumstances. I will explain this disaster plan later in this presentation. Now it's time to zoom in on the part of the emergency call that the emergency call takes. Europe asks their country to provide one unique emergency number to reach all the emergency services. The chosen number is 112. In 1964, in Belgium, it was a number 900. Later, it's 2. When a citizen calls a number 112, their call is forwarded to the nearest emergency call center, 112. If the center is currently overloaded with too many calls, an overflow system is activated, which automatically forwards the call to another 112 center in the country. People who dial 112 are first given a menu to let them choose between police, fire brigade, or medical assistance. The dispatcher also receives some information on the screen: the telephone number of the caller, the address at which the telephone number is registered, and possible the name of the subscriber of the number. Once the caller has made a choice, they end up with either a police dispatcher or a medical or a fire dispatcher. The 112 emergency centers in Belgium are physically divided into 2 different centers. At the one part, the emergency center for the police, and at the other part, it's the one for fire brigade or medical assistance. For several years to have them fully merged, but it's mainly confronted with legislation regarding medical confidentiality and police secrecy or judicial investigations, which are still standing in the way of this merger for the time being. The call takers of the fire and medical call center are trained for handling the emergency calls of both these disciplines. In Belgium, we have 9 emergency call centers 112. The organization of the call center is a collaboration between the Department of Internal Affairs, which covers the police and fire services, and the Department of Public Health for the medical chain. An emergency call center plays a critical role in the initial response to urgent medical situations, coordinating a structured process that ensures swift and efficient care. Once a call is received, the dispatcher initiates one of the 56 intervention protocols carefully chosen based on the information provided by the caller and a series of questions that has to be answered. These protocols are bundled together in a scientifically validated manual called the Belgische Handleiding voor Medische Regulatie. The protocols guide the dispatcher in making a decision-based determination of the severity level of the incident, ensuring that resources are allocated appropriately. Following this assessment, emergency medical services are dispatched to the scene with the necessary urgency and equipment. Simultaneously, the dispatcher determines the most suitable hospital of destination, factoring in the patient's condition, hospital capabilities, and proximity. Throughout this process, the dispatcher provides clear and calming pre-arrival instructions to the caller or bystanders, aiding in an immediate care and safety until the professional help arrives. In this picture, you see an example of such a protocol about an unconscious. By asking specific questions, the 112 call taker is guided through the flowchart and will arrive at a certain severity level. This severity level is linked to a certain deployment and dispatch plan for resources. And for example, for severity level 1 and 2, two vehicles will always be sent out, namely an ambulance and a MUG, which is a vehicle with an emergency doctor and a nurse. I will come back to the various deployable resources in more detail shortly in this presentation. You can see this dispatch result in the red section of the figure. These are usually very critical situations where an urgent intervention by a specialized doctor is necessary. Severity levels 3 and 4 are indicated in orange and lead the dispatcher to a PIT to send out. This concerns an ambulance in which a specialized emergency nurse is present. Severity level 5 in the yellow section is intended for an ambulance 112, and this is also the last intervention of the EMS system. The lowest severity levels refer to general practitioners. At this moment, we must know that the on-call services of general practitioners is not well organized everywhere in the country. Just as with non-urgent patient transport, orders can not be assigned to general practitioners, on-call service can still end up with the EMS system and can be overloaded by these calls. So there are a few possibilities for a citizen to reach the emergency number 112. They can use a telephone by dialing the number 112, but there are also a few alternative methods. The government has developed an app 112 compatible with all operating systems. Once the app is installed on your mobile phone, you can feed it with relevant medical background information. If you want to call the emergency center in this way, the app will first ask you to choose a desired discipline. You will then be connected to the operator by the speaker of your device. Another advantage of the app is that not only your identity data and the medical information that you provided are displayed on the call taker screen, but also your location data is shared live with them. In Belgium, they are now also looking into immediately activating the camera on the caller's device so that the call taker can watch the incident site via streaming video. The last option to reach the call center is an SMS or a chat option. This communication takes place via a different contact number than 112, and this number is only reserved for the deaf and hard of hearing. This population group is assigned the chat number via their own network. It's not totally spread under the population. So we will go more into detail. We will go about the different resources that provide emergency medical assistance in Belgium. These services that move around the field mainly consist of these three resources, but medical helicopters from hospitals or from the Belgian Army can also be added. So you see these resources on the screen. An ambulance 112 is the most basic means used on the ground. The vehicle is manned by 2 first responder ambulance workers, and their training consists of 124 hours of theoretical lessons, followed by 40 practical internship in the emergency department. Afterwards, the ambulance worker receives an induction program within its own department. An ambulance provides basic care and is assisted by a MUG if it concerns a critical victim. In Belgium, there are 384 ambulances spread across the entire territory. And last year, these ambulances together performed 850,000 EMS interventions. A variation on the ambulance is the PIT. This device is dispatched at severity levels 3 and 4 by the emergency call center. And a PIT is identical to an ambulance, except that one paramedic is replaced by an emergency nurse. This nurse is trained to perform actions under certain circumstances that normally are reserved for doctors. In this way, they can reduce the dispatch of a MUG or provide more comfort to a patient than an ambulance could do. In Belgium, at the moment, there are 57 PIT teams, and they are always connected to a hospital with an emergency department. And then the last resource is a MUG. It's a medical urgency group, it calls in Belgium. So this is the most specialized emergency resource and is a rapid intervention vehicle loaded only with an advanced life support materials and with an emergency doctor and an emergency nurse on board. Unlike a PIT or an ambulance, this vehicle cannot transport a patient and always comes in support of an ambulance or a PIT on the field. A MUG always departs from an emergency department, and there are 85 teams throughout the country. In approximately 25% of the EMS interventions, a MUG team is sent out by the emergency call center 112. In all cases, the patient is taken to the hospital with a specialized emergency department. These are departments that must meet certain standards regarding staffing and permanence. They must be available 24/7 to receive patients and must have a minimum number of emergency physicians and emergency nurses on the floor. The size of the department is not specified, which means that the quantitative reception capacity may vary. Also, not every hospital with an emergency department has all the specialized treatment options, such as burn care, neurosurgery, neonatology, etc. The task is then to stabilize the victim in the first phase and then transfer him to the more specialized center by means of an urgent inter-hospital transport. In the last part of my presentation, I would like to briefly explain the approach of a large-scale emergency. The approach of disasters is multidisciplinary. That means that the coordination structure is set up in which all emergency services, we call them disciplines, are represented. This concerns the fire brigade and rescue services, the emergency medical assistance, the police, logistical assistance, for example, provided by the Belgian Army or the Red Cross, and finally the information discipline. These disciplines work together in a command post under the leadership of a director of that command post. Each discipline provides the effort required to deal with the incident and can therefore fall back on its own emergency plan manuals within their own discipline. An example of the script for the medical discipline can be seen on this slide. There are 3 levels of medical intervention plan. The first level, which involves 5 critical patients or 10 victims with an unknown degree of severity, or a large-scale evacuation of a building site even without victims. When more victims are involved, we speak of an increased MIP, in which more resources are activated as standard. And the greatest effort is made when a maximum is announced, 50 seriously injured victims, or more than 100 victims with an unknown degree of severity. This phase was mainly foreseen after the terrorist attacks in Brussels, in the Brussels subway and the National Airport in 2016. The medical services are responsible for the coordination of the medical assistance on the ground, in particular the reception and registration of victims, the triage and stabilization of victims in a field hospital, and the distribution and transport of victims to the hospitals. They also provide help for those involved who have not been injured in hospitality centers to be set up. All this in collaboration with other disciplines and authorities. So to conclude, I will briefly summarize the 2 basic principles of the EMS system in Belgium. On the one hand, the system is mainly based on dealing with individual emergencies in a structured and well-organized manner on a daily basis. On the other hand, the system must be able to be scaled up quickly in the event of an unforeseen large-scale event with many seriously injured victims. Mono and multidisciplinary emergency plans have been developed for this and are practiced several times a year in the country. So I hope that during the short presentation I was able to guide you a little in the world of EMS in my country. Please feel free to ask your questions in the Q&A session later in this presentation, in this webinar, if there are things that are unclear or need more explanation. I thank you for your interest and Accreditation Canada for the opportunity to present our work within this international context. Thank you very much.
Thank you, Martin.
So I am glad to announce the next speaker of this webinar. It's Christopher who takes the word for me.
Thank you very much. Share my screen. Hopefully you all can see that. So Let me see here. Okay. Cool. So thank you everyone for joining me today on this very important talk. Again, I am Chris Fahey. I'm the Accreditation and Logistics Officer with Lethbridge Fire and Emergency Services. So today I'll be talking about how Lethbridge is navigating accreditation in a pre-hospital setting. So what that means for us as an integrated fire and EMS service, the unique challenges in our region, and some of the great work happening as a result of the accreditation journey we've been on. A little about Lethbridge, if you're looking to try to find out where we are. It's a city in southern Alberta with a population of around 106,000. We're the largest urban center in the region outside of Calgary. And we provide services not only to our city, but also to the surrounding rural communities. We experience extreme wind patterns, and in the winter, some warm winds called Chinooks can cause rapid weather changes. So it can go from -20 to +20 in the span of a few hours almost. These sudden shifts, especially on our rural roads, can create added challenges during our emergency response. So we're situated near some beautiful and major landmarks in Canada, like Waterton Lakes National Park, Head Smashed In Buffalo Jump. There's some beautiful scenery, and if you're in the area, please reach out. I'll try to be a tour guide the best I can. But our location also means we're a hub for interfacility transfers from surrounding smaller hospitals, and we serve as a launch point for patients requiring specialized care in Calgary, which is about 2.5 hours away. Those transfers can tie up our units for at least 6 hours per trip. So what does an integrated service look like? So we are one of 7 integrated services here in Alberta, but we are the oldest. We first established as integrated in 1912 when the fire department took over the ambulance. All 6 of our frontline fire apparatus are ALS equipped, and our firefighters are also trained as advanced care or primary care paramedics. That allows us to send the closest resource, whether it's an ambulance or a fire truck, deliver care as quickly as possible. So if fire arrives first and it's an ALS type call, our advanced care paramedics will begin care immediately, and they'll often ride with the transporting crew if it's a BLS or basic life support unit from Alberta Health Services or surrounding communities. If it is an ALS unit that's responding to backup fire who's there first, we direct our fire role is to stabilize, form a patient history, and assist the arriving crew. Speaking of the ambulance, so we have 14 ambulances here in Lethbridge. They're all ALS with a minimum of 1 advanced care paramedic and 1 primary care paramedic. But frequently we have 2 advanced care paramedics on the ambulance, which is kind of our gold standard here. How's a call look like if it does come in? So EMS 911 calls in our area, they're routed to AHS, Alberta Health Services, dispatch in Calgary. They assign our ambulance, and then the crew is notified via radio and a station alert to respond. If the crew on scene determines that they need additional help, say they're doing a lift assist, a scene access, or they just want some more clinical support, our crews can then contact AHS dispatch, who then contacts our fire dispatch to send the fire unit. As you can imagine, that extra step can create some delays. Since the 2 systems are not unified, there's often a back and forth of phone communication, a little bit of phone tag between dispatch centers. We also have situations where fire is automatically dispatched for high acuity responses. So our chest pains or cardiac arrest or motor vehicle instance, the fire apparatus is auto dispatched as well. So that's a little bit quicker response for them. But in many cases, it will take our ambulance crews to request support, which is not always immediate. Our call volume here in Lethbridge, it's around 26,000 EMS calls for our ambulance. They range, like I said, from lift assist, overdoses, chest pains, traumas, you name it, we've probably responded to it at some point. Currently, our EMS crews also respond to support our fire scenes as fire resources. We are integrated, so it's a dual role. So their fire gear is actually on the ambulances as well. This is expected to change in the near future as we refine our role clarity, but that's how it is currently. On the fire side, we see about 7,500 EMS related calls a year, making medical calls a bulk of our fire's response volume. The rest range from fire alarms to rescues and structure fires. Another challenge we face, and one that stretches our staffing, is the frequency of interfacility transfers or hospital-to-hospital or care facility transfers, particularly when we're transferring these patients to Calgary. Like I said before, we're kind of the hub, so patients will come to Lethbridge, and then we generally transfer them to Calgary for a higher level of care. These trips often take 6 hours or more, significantly impacting our local coverage. But a lot of you, I'm sure, came here for accreditation and what we're doing and the benefits of our accreditation. So how did accreditation change my organization? Well, although we have been accredited since 2012, historically, we always assumed we knew what our community wanted, and we kind of had the we know best mentality. But in meeting some accreditation requirements of patient, family, community engagement, we realized we actually did not know what they wanted. And we learned how vital it is to include these stakeholders as part of our decision-making and give feedback to see our initiatives working and is it what they want. So now we started to do community engagement booths where I set up a little system, almost like a Plinko machine, where they can actually put in what is their priorities for their fire and EMS department. We collect feedback cards. We use online surveys and ones that are attached to our bills as well, which may not get people at their happiest, but hopefully they will still give some honest feedback to us. We also ask if people want to join our patient review committees. So as we continue to refine and update our policies, we incorporate their feedback. This is still a new process, but one we're very excited about. The top things that our community has told us is overwhelmingly, they want a fast response, qualified personnel, and modern equipment. And we're listening. These aspects we are incorporating into business plans and our future goals. It is also helpful when we have our internal stakeholders participate in these feedback devices, such as city councilors, our directors, as they can see the results from the community and they can put their own input in, which whenever our directors or councilors put their input in, I definitely have a quick look to see where is it that their priorities are as well as ours. Another area we found we needed to reinforce was our employee recognition. Every organization out there has their staff that excels. But when we sent out our accreditation engagement survey, we noted that we had to do a much better job of recognizing our staff. So the process prior to our last cycle was we would send out kudos via email and kind of a great job, pat on the back, and that was generally about it. So we saw we had to do a better job. So now, what do? We host survivor reunions. So we bring together responders, families, the patient, the media, their families, and we post it on our learning management system, and we celebrate it. We frame their ECGs and their return of spontaneous circulation with the responder signatures and the family signatures, and we add them to a survivor wall. It's very powerful and emotional. As you can see from the picture here, the wall is growing, and that's one thing we are very proud of. We're hoping to keep expanding that wall. A little shameless plug for the department is with these improvements that we're doing, Heart and Stroke highlighted us in 2024 for our cardiac arrest improvements of our high performance CPR and how we're trying to do a better job of staying on the chest and giving patients the best chance that they can. So I may be the accreditation officer here in Lethbridge, and I'm sure very many of you feel the same way. It doesn't take just one person though. It takes a village. So we have lots of experts, lots of great people in our organizations. So we pull in our subject matter experts across the organization to help us with our accreditation. They're the ones who are the experts in a lot of these documentation. So pull them in. What I found was some were very hesitant. They were unsure about writing or documentation for our policies and our procedures. But one of the most important lessons I learned through this whole process is the value of a living document. Just because something was written and sent out doesn't mean it's completely carved in stone. If a policy isn't working or frontline members see a better way, we change it. I try not to take it personally, which I did in the beginning, but one thing that I'm very much learning on is that instead of focusing on, I wrote this is how it's got to be, focused on what's best for the department, what's best for our people, what's best for our patients. So that means listening, revising, and improving as we go. This mindset and not being so attached to these documents has really gotten more members engaged and more willing to speak up to help change and guide our process. I found my role has shifted more to guiding the process, edit where needed, but they own the content. Those of you who are the accreditation leads know sometimes trying to track our compliance can be difficult. So I'll tell you what I do here in Lethbridge. We use Microsoft SharePoint and Planner. So we assign members tasks for approvals. And yes, those of you who are managing these profiles know trying to track down people to complete their work can very much feel like herding cats. But programs like Planner and others can help guide them, get them involved, and it helps build ownership and pride in the whole process. I'm sure, like me, many of you have been asked, so why does accreditation matter for a service like ours? The answer that I've given, and one I believe in, is it gives us a third-party lens to see where we're doing things well, where are our gaps, and where we need to grow. Everyone believes that they are the best service, they do things great, but how do you know? How do you know unless someone from outside the organization is coming in and going, yeah, this is great, or have you thought about this? So it helps us ensure we're delivering safe, quality care and not just assuming that we are. It's not a checkbox, it's continuous improvement cycles. And it made us better. For our patients, our community, and our staff, we're better. So that's a quick look at Lethbridge's journey. We're still learning, we're still improving, but we're very proud of how far we've come. So thank you for all the work you do in all your respective areas to advance healthcare quality. And thank you for including EMS in these important conversations. So that is it from me, and I will pass it on to Michael.
Thanks, Christopher. Appreciate it. Just going to get my presentation up here. Okay. Hopefully everybody can see that okay. Thank you again to Accreditation Canada for having me today to speak. I'm happy to be here and looking forward to chatting about the coordination of land ambulance and air ambulance systems with respect to Ontario. Very quickly, my name is Mike Langevay. I'm a critical care paramedic by training. I worked with EMS in Ontario for about 16 years. I've had the pleasure of working Northern Ontario and Southern Ontario, which I'll speak to that dynamic shortly, as well as worked at all levels of paramedic in Ontario, which is primary care, advanced care, and critical care. My current role is the Director of Clinical Affairs for Ornge. So as Kirill pointed out at the beginning, my oversight is elements of clinical care that are being provided by our clinicians across our system. In addition to that, I'm a surveyor for Accreditation Canada. I had the pleasure of traveling across our country to see a number of EMS systems, and I've really enjoyed that experience. Context matters, and so just to provide a little bit of a background on Ontario, Ornge is the critical care and inter-facility transport provider for the province of Ontario. Ontario is a very large area. It's about 894 square kilometers, or roughly the size of Spain and France put together, if you're joining us from Europe. So very large transport times, very large distances to cover, and that is often the challenge we face the most, which is time and distance, and trying to overcome those to provide care to our patients. In a little bit more of a detail for Ontario, you can see our base locations scattered across the province. You see little helicopter symbols or plane symbols, that's or little ambulances. That depends on our asset that we provide in that location. So airplanes versus rotor wings versus ground critical care transport. This is really ultimately a good slide that demonstrates the biggest challenge we face in Ontario. That orange line that divides the southern part versus the northern part, this is a big difference. It's almost a challenge of providing two different services across one space. The population you can see of Northern Ontario, or above that line, is only 789,000 people, which represents about 6% of the population living across 90% of that landmass. Within that 90% of that landmass, we have 133 Indigenous communities, many of which are fly-in only, which means that they have to be accessed by airplane or by ice road in the winter. Practically speaking, access by ice road in the winter is not feasible from an emergency perspective, but is sometimes the only option that we have given weather. Conversely, if you look at the Southern Ontario space, we have 13.5 million people living pretty well along one highway. It's called the 401 corridor, for those not familiar with Ontario, which runs from the United States to Quebec, where we have most of our population, and indeed you can see a significant number of our resources there providing care. Our model, unlike some of the other speakers you've heard today, is two highly trained critical care paramedics in all of our assets. And those paramedics complete nearly 5 years of training to get to the critical care level in Ontario. And as mentioned, they would be primary care paramedics, then go back to school, become advanced care paramedics, and then finish up by coming to Ornge and completing their critical care training with Ornge, which is approximately 2 years to provide care. So that's the context that we work in. And so how do we coordinate? How do we work with our land ambulance partners? And what does that look like? Within Ontario, we have a number of systems of care. We have stroke systems, we have trauma programs, and we have our STEMI programs. All of those programs within the province of Ontario are underpinned by SUSIA trauma standard. We have a stroke standard, and all that is underpinned by what we have, which is called the Air Ambulance Utilization Standard. The Air Ambulance Utilization Standard is a piece of legislation which is published by the Government of Ontario, which describes when local EMS dispatch centers or land ambulance partners can request a response, or when interfacility transports can be looked at for Ornge. So within the land ambulance standard, it will describe either time or distance, which will permit the hospital, if it's an interfacility transport, for requesting Ornge as a transport agency to provide the interfacility transfer, as opposed to using a land partner, or from the land side of EMS, how they can request the utilization of an air ambulance. In order to illustrate this a little bit better, I'm going to use trauma as an example. This is certainly probably the most common response that we see from our land ambulance integration. And again, not to highlight a theme, but we're looking at sort of the challenge of distance over and over again. Here's the province of Ontario. In it, you can see the 9 lead trauma centers that we have across the province. You can see 1 through 7 live on that southern side of the border, with 2 living in the northern side, being Sudbury and Thunder Bay. Great deal of space if you look at the upward pink area. Again, overcoming all that space to get to number 9, if you think about the golden hour of trauma being the standard of care. And so this is always our challenge. 40% of our patients, as it mentions here, do not have access to a trauma center within 60 minutes. So again, thinking about that golden hour, and 15% or not even within 60 minutes by air transport. So Again, this is our biggest challenge that we face is how does Ornge partner with our land systems, and what does an effective system look like to try to overcome some of these distances. Quick demonstration of how the system should work or does work in its most optimum way. So there are 22 land ambulance dispatch centers across the province of Ontario. So as Kirill mentioned, that's 911 for folks in Canada. So if there's a car accident on the street, someone calls 911 and reports that incident or that trauma, that 911 call will get routed to one of 22 centers across the province. Through a series of questioning from the 911 operator, they will determine if the patient meets the field trauma triage standard, as previously mentioned, and can then auto launch a helicopter to that call. That process is done through our dispatch centers. So the dispatch center of the 911 intake will forward that information to Ornge's operations control center, our own dispatch center. Will provide the latitude and longitude of the call and can launch the helicopter to scene. In those cases where the timing permits, our helicopters will arrive onto the scene of the incident, be it a car accident or be it some other trauma, land and be able to meet the patient and start providing care immediately and transport the patient directly to a trauma center, one of those 9 trauma centers that was mentioned. When we think about the challenges of Ontario, again, in the context of distance, this is how our transports often work, and this is what we classify as a modified scene call. In these cases, when the call comes into the 911 center, again, they can notify our operations control center, who will begin to look for a resource depending on where it is. Again, if it's close or there's a helicopter response within a reasonable time frame, they'll launch our helicopter. In some cases, as mentioned, if these are the fly-in only Indigenous communities, or these are some of the areas up in the Northwest where helicopters aren't practical from a time perspective, they could consider fixed wing transport as well and begin launching a fixed wing response. In these cases, local providers will still meet the patient as normal from a 911 response. And then depending on our response time, will meet us at a regional hospital or a non-trauma hospital where our crews can link up with the patient there and complete the final transfer from the regional hospital to the lead trauma center, depending on distance. Again, the overall time to the lead trauma hospital in this case would be considerably longer when you think about having to stop at an intermediary area. But however, stopping in those regional hospitals does allow for initial treatment by local physicians, some damage control type procedures if required. But these things have also led to some innovations within our system. So within the Ornge system now, many of our assets are carrying blood directly on their assets, their helicopters or their planes. And this is to be able to start providing care, appropriate trauma care to patients who may have longer transport times to lead trauma hospitals. So many of our crews, particularly in Northern Ontario, are able to initiate blood during transport, along with a number of other life-saving procedures during their transport. All in all, one of the things that I hope is an important takeaway from this presentation is that the operational interface with ground systems is the most important. We have really excellent dispatch systems. We have lots of excellent legislation and lots of excellent rules to underpin how and when we would respond to a case. But in the end, in order to overcome the challenges we face of time and distance, we need high reliability of our operational interface and our local partnerships. And so that means that in the fixed wing world, we need airport availability. That means plowing runways. That means fuel available in all of the many different remote airports that we need to transport into. That also means strong partnerships with our local EMS providers. So within Ontario, there are 58 municipal ambulance services that are run by the municipal level government. Those are the partners that we have to work with. And in many cases, they're strapped in terms of their call volumes. They're facing high rates of 911 activations. And so we rely heavily on them to be able to do those airport transfers, to pick up our crews at those community airports and drive them in and out of facilities. And that is a huge burden on them. And we continue to work with them to establish those types of partnerships. In our fixed wing world, this is about, again, heliport availability. So in many cases, if you don't have a heliport at your receiving hospital, or you don't have a heliport at your sending location, it becomes very challenging to utilize what is the best feature of a helicopter, which is being able to land on a roof of a building. And so we rely heavily on working with our hospital partners, and we rely heavily on working with our provincial government partners to ensure appropriate helipad access across the province of Ontario to make sure we can use these assets the way they're intended to be used. Of course, on scene calls, we're able to land on highways, on roads, in fields, wherever we need to, but those are unique circumstances and obviously aren't things that we would rely on for inter-facility transport or other types of non-emergency response. And finally, as a result of some of these challenges that we faced regularly with our local land partners, again, our local EMS services are very busy transporting patients within their own communities, within their own 911 systems, and oftentimes doing these airport transfers for Ornge becomes very difficult, and they simply just don't have resources to be able to do that in a timely manner. And so Ornge has begun the initiation of what we call our PCLA system, which is our primary care land ambulance system. So this is a traditional ambulance that is staffed by 2 primary care paramedics, and we've placed these ambulances strategically around the province in key locations where we know local resources are exhausted, or the transport time from the airport to the hospital is extended, i.e. the airport is not close to the city or not close to the hospital. And this allows us to be able to do the transports in a timely fashion in a way that doesn't disrupt local 911 operations and doesn't incur any delays from our side from the airport. Ultimately, we need to know how we're doing. And so how do we decide as an organization, are we meeting the needs that we say we want to, and how do we drive further innovation, and how do we drive further system improvement? As mentioned, Blood on Board, our primary care land ambulance system, these are all the result of quality improvement work that we continue to do at Ornge. So how we measure ourselves, this is a very simple graph, but what I'd like you folks to take away from this graph is that we look at everything operationally, and we look at everything clinically, and then we look at it at a granular level, and we look at it at an aggregate level. So this is sort of the 4 quadrants of how we assess ourselves. Everything that is on the high side of the quadrant is what goes to on the low side of our quadrant is what goes to our board, and everything on the high side is what goes to our various committee levels. Everything on the left side is what goes to our clinical medical advisory committee. Everything on the right is what goes to, again, some of our operational committee level reviews. So things that we look at a granular level from an operations perspective, we look at our performance data. So this is our response time, this is our transport times. These are the things that help drive some of our innovations around where do we put our next asset when we're fortunate to be given another asset by the government. Where does it need to go? We use data to drive that decision. Where do we put our PCLAs? Where do we put those primary care land ambulance? We use our operational data to help guide that around overall response times and overall transport times. From an aggregate level on the clinical side, what do we look at? We have something called what we call clinical metrics. Our clinical metrics are aggregate level reviews of all of our clinical care that we provide. So on an annual basis, our medical advisory committee reviews our clinical practice guidelines, which is the standards of care that we provide. How do we treat people, with what medicines, with what procedures? We use an evidence-based approach to review that. So we'll use physicians with subject matter expertise in neurology and obstetrics and emergency care and ICU care to review all of our clinical practice guidelines and determine that we are providing the care that meets best practices within the transport system. From there, we derive what we call clinical metrics, and all of our patient care records. We do about 30,000 calls a year, and all those patient care records will get reviewed in a filtered manner to be able to determine, are we meeting the clinical care that we espouse to meet at a system level. And we use that information to then guide our education for our paramedics, who complete 96 hours annually of continuous medical education. That is the basis for guiding how we provide care and providing education to our staff. At a granular level, we look at individual calls for review. So every time we perform an airway intervention, i.e. an intubation or an emergency crike, those are types of calls that are reviewed by our medical team, where there's individual feedback to our paramedics that's provided. Our paramedics use video laryngoscopy, and so often we can upload those videos and we can review the case with our paramedics at an individual level, making sure that our individual clinicians are getting specific feedback on the care that they provide in high stakes situations. At a granular level, from an operations perspective, we'll look at significant outliers in terms of delays, significant outliers in terms of equipment failures. And again, all of those events are reviewed by any one of these committees that you see in orange. But at the aggregate level, this is all reported to our board. And I think it's important to recognize that our board and our medical advisory committee, our board quality of care and medical advisory committee, all contain patient advocates and families as well, making sure that we're following Accreditation Canada's best practices around patient-centered care, family-centered care. Finally, a little bit about our research and quality initiatives. Again, I spoke to Blood on Board. You'll see that we've done a lot of research internally with some of our physicians within Orange, who are doing some work on secondary activations and cancellations. So this is one of the areas that is a focus for us within Orange. Often during the call information process or in a 911 process, we'll get activated by local dispatch centers for EMS. We'll begin our launch to transport to begin our transport for that trauma patient. But we're canceled by local land partners because the patient doesn't meet the field trauma triage guideline or doesn't meet any of those legislative underpinnings that we talked about for air ambulance activation. So we get canceled while we're already flying there, return to base, only to be activated a couple hours later once that patient arrives to the hospital and there's some other injuries that are found. So work is being done to look at some of the information across our system to see how can we fine tune our criteria for ambulance utilization and our criteria for trauma response, so that we're not wasting time for that patient getting to a trauma center by cancellation and reactivation and cost from a secondary activation perspective. We're doing ongoing quality improvement work with our stroke networks and our trauma programs across the province. All of our EVT centers, as well as our trauma programs that I mentioned across the province, all have their own networks and their own quality improvement groups. We sit on those groups and we work with them to share data, to ensure that we're doing our best to provide timely access to EVT, timely access to trauma, and continue to see where we can make improvements there. From a patient care related perspective, again, I mentioned the clinical metrics. We continue to review these against our clinical practice guidelines to make sure that we're providing the best care, we're providing the most informed care we can to our patients, and looking at processes there. Again, we do individual audits, as I mentioned, for any specific cases or our high-risk cases. Our paramedics do intra-aortic balloon pump transfers, they do ECMO transfers, they do high-risk intubation. So lots of high-risk interventions that we provide, and we want to make sure that we're providing our clinicians with feedback on those cases. Yeah, so those are our pieces. That is all I have to talk about today. I appreciate your time. Thank you very much for listening to me. I'm happy to take any questions about how we interface, but I think one of the big takeaways for me that I'd like to share is just making sure that operational piece is important. You can provide excellent care. We know we provide excellent care. We know that when our paramedics get to the patient side, they're doing the right thing. They're meeting the expectations that we have, and our patients are receiving optimal care from our clinicians. The challenge is making sure that we can get there and making sure we can get there in a timely and predictable manner. Thanks very much. Back to you, Carl.
Thank you, Michael. Thanks to all the speakers. Great presentations. Very interesting perspective coming from Europe, from Belgium. So thanks, Martin. Interesting to hear what's going on in Alberta. Christopher, great presentation. And Michael, Ontario. air ambulance work. It's absolutely fascinating. So thanks again. We've been receiving questions, I should highlight, from various countries. That's also very impressive. We've been receiving questions from Finland, from Qatar, from Barbados, Indonesia, Tunisia, and sorry if I didn't mention a country here, but I was really impressed by the variety of questions and comments coming from various parts of the globe. Christopher, also I noticed that you answered almost all the questions in writing. Probably we will get back to some of those questions because there were some interesting questions, and I think that will be interesting for the audience. But before we do so, I wanted to highlight once again that we will send the presentations to all the attendees. Well, we will put them on the landing page of our website. We will share with you the link. So if you miss something, if you miss something, you will be able to go back, download the presentation, look at it once again. So this is something that we will do in the coming days. We will share with you the recording of the webinar, and we will share with you a certificate of attendance. Just a few words about the upcoming webinars that we're planning. So there will be, I believe, the next webinar that we will be doing, and we will be doing many various webinars. So there will be a webinar on June 12th. You will receive some information on this. It will be dedicated to the World Accreditation Day. There will be a webinar on pharmacies, another webinar on World Patient Safety Day. That one will be more in the fall. So stay tuned. We will keep you informed. Another information I wanted to share with you, and I believe we chatted about this today. We will be at the EMS Congress in Stockholm in Sweden in early June. Those who will be attending this event, please let me know. I will be pleased to meet and chat with you. So once again, that will be in Stockholm in early June, and at the end of this session, please fill out this survey. That's important to us. And now we will go back to the questions. So we received various questions. I will try to bundle them because there are some recurring themes among those questions. So let's start with a question about, and I think this is more for Heather, but all other speakers feel free to jump in to answer as well. So what's the difference? We're an organization, we follow patient and family-centered care, and you're talking about people-centered care. Basically, what's the difference between patient and family-centered care and people-centered care? Heather, I guess this is the question for you.
Thanks, Kirill. Yeah, there's lots of confusion because there's many philosophies out there. There's patient, there's person-centered care, and we're not saying one is better than the other. We follow people-centered care from the World Health Organization, and in fact, patient and family-centered care is grounded in it. People-centered care is broader than that patient or person-centered care because it's not only those clinical encounters that you're dealing with, but it's paying attention to people in the communities. And the biggest thing of all is the awareness of everyone involved. So staff, board. So it's a joint decision. It's everyone is part of the conversation. We did so much work in the early 2000s on bringing that patient voice forward. We forgot about that voice of the healthcare provider. People-centered care brings things back to center where we're all part of that circle of care and conversations are being had.
Excellent. Thank you, Heather. So going back more to EMS related questions here, there was an interesting question that Chris, you has already answered, but I think it will be interesting to go back to that question. I'm trying to find this on Zoom. It was a question about artificial intelligence, how basically you're using it, and are there any specific tools that you're using? I can't find the exact question, but Christopher, maybe you can remind us the question because you've answered this.
Let me see.
What? Okay, I just found. What do you what do you do if the organization is using artificial intelligence in creating policies, patient safety, and other procedures as replacement to human assistance?
And you want Heather to answer correct? Oh no. Okay, sorry. So for me, yeah, AI is it's the future. It seems like it's everywhere right now. But that being said, it doesn't replace our people. It doesn't replace the people who are in the field, who are actually doing it day to day. It doesn't replace our patients, what their needs are. It's a tool if you need it to maybe find different avenues, different thought processes, sure, but it will never replace our own staff and subject matter experts. So use it to assist you, but not to replace.
Does anyone want to complete this answer? Maybe Michael, any comments, or Martin? Europe, what's the European standpoint on artificial intelligence?
We are starting to look also to the possibilities of artificial intelligence in our work, but it's a very far way to go for us. So we are at the start or the beginning of brainstorming about the possibilities, but there's not a lot of things that we can import in our organization of the EMS on the field at this moment. So we are working with, for example, services for providing monitor defibrillators, dus the monitoring of the patients, to interpret the electrocardiogram of the patient with a heart disease by artificial intelligence, and make a conclusion, because the ambulance workers are not trained to interpret the ECG data themselves. So that's something that we are working on at the moment.
Okay, let's move on to the next question. I think this one is coming to us from Finland, but it's interesting to discuss this. And so the person, I won't be able to actually pronounce this person's last name, but I'm sorry for that. The question is about dual roles in ambulances. Can you maybe expand a little bit on this one, Christopher? Because you answered this question, but I know that this is something that that is a little bit different between Europe and North America.
Yeah, so for the dual role here in my organization is fire can do both. They have the ALS equipment on the fire side, so they can do treatments. They can do basically everything except transport. The EMS side, they're also dual trained, so they're firefighters as well as paramedics. So the fire gear is on the apparatus. So if there is a structure fire, for example, the first arriving unit, possibly two, would be fire resources, and then the following units would be there as EMS. So if someone gets hurt, etc., then they would use that role. We are transitioning out of that, it looks like, in the very near future, to EMS being EMS units, but our staff will still be dual trained. So they can still work both apparatus, but that actual EMS unit will just be doing EMS calls in the near future.
Is it the same in Europe, Martin, in Belgium?
Can you please tell me the question again, because I had a little disturbing of my network. I didn't get the question.
So you in Alberta, at least, paramedics are trained with they have dual roles. They can be both firefighters, basically, and paramedics.
Yes, it's the same in our organizations. So we have also firefighters and paramedics in the same organization. It's only within the fire zones, because there are also EMS partners from private companies or that are organized by hospitals. So, but when the ambulances are organized by the fire zones in that regions, we have indeed the same possibility that there are ambulances who are the same person who can do the both of the tasks, and we see that as a strength, because they have two disciplines, as we call it, that they can work on the field. So when they are acting as an ambulance worker, they have also the insights of the safety measures that the fireman has to take, or in the other role, when they are as a fireman called for a burning house, they arrive. They can also do some actions for the victims that are involved with the house burning before the ambulances teams arrive. So that's for us, we see it as a strength.
Michael, there was a question for you that just arrived. Thank you so much for your presentation. Do you feel there is a potential for trained community responders in remote communities? Is there an opportunity to enable and evaluate those kinds of programs in communities without local emergency services available?
That's a good question. It's very timely. So thanks for that. I think one of the things that Ornge is taking on very recently, it's still very early, is we've been asked by the province of Ontario to adopt an emergency first responder program within those communities. And so we're in the initial stages of setting up that. So what that will look like exactly is still, I think, a little bit to be determined. But in essence, there's a there's a program that exists today already that we're joining to support and try to spread that across the province a bit more. But it is local community members in a volunteer fashion working as first responders to provide care to folks at their homes and their communities, and assist them in transport to the local nursing stations that exist within those remote communities. Within the nursing stations, or within the Indigenous communities themselves, the nurse practitioners, or the nurse clinicians rather, who work within those nursing stations often aren't permitted to provide care outside of the walls of the nursing clinic itself. And so trying to create a system that, similar to an ambulance system, that allows access, mobility, and ability to get to those nursing stations is important. And so we're working on that program now at Ornge, which will have sort of an emergency medical responder level type care, some initial sort of public access type care that can be provided. Yeah, we're working through that process right now and developing that. So we're still building our team. So people want to come work for us too. We're looking for good people in that space.
Excellent. This is a great company. Did you explain, Michael, why Ornge is spelled in this fashion? Where is the A?
I really wish there was a great story behind that. There is not, and I don't know the origins of it, other than it is not an acronym. It doesn't stand for anything. It's itself. It's its own company name.
Excellent. Well, a very good question. I will answer this one. Which are the accreditation institutions for medical transport in Canada and in Belgium? That's a simple question. That's basically Accreditation Canada. We do accreditation in Canada. We do accreditation in Belgium, in many other places. We do accreditation for various services, including EMS, so emergency medical transport, urgent and non-urgent transport. So feel free to reach out to us where I can explain how it works. Then we have a question. Just one second. I'm looking at different places to pull out the questions. Yeah, there's a question for you, Martin. What is the cost of emergency medical services for individuals in need in Belgium?
The cost is always the same in Belgium. The cost for my organization for one intervention is about 430 euro. That's approximately $500 US. That an intervention costs at the organization that has to at the fire zones, who has to deliver the ambulance services to the patient in need. So, but it's the patient has to pay 72 euro from that amount. So that's about 16% of the amount is paid by the victim, and all the rest of the amount is paid by the government.
Okay, interesting. Another question about people-centered care. Why is it important? This is a question that comes up quite often. We understand the people-centered care, why it is important in the hospital environment, but basically, why is it important in the pre-hospital environment? Why is it important to get the patient perspective where we as EMS and paramedics know what patients feel, we can speak for them, right? So that's, I guess, the question for Heather.
Well, it's kind of like that AI question. So nothing beats that voice of patients and families. And, through my learnings with Medavie, like I've been on a ride along and I was so impressed because they have one paramedic really focused on the family and one focused on the patient. So really working in that people-centered care way where conversations are being had. No one knows that patient's history the best more than the patient or the family. And in their greatest time of need, you have to really collaborate. And that's where people-centered care comes to life. And like Christopher and Michael and Martin have brought examples of how this is being done. And it looks different because it's adapting to different scenarios. But it's so important, and there's creative ways to do it, just like Christopher did examples of that. And I really love going to the community. You can get insight into what their needs are, and those learnings are invaluable. So that's why it's important.
Does anyone want to add anything to that? Why the patient voice is important?
Just add from on the air ambulance perspective, it's no doubt that any ambulance call or any ambulance case is scary for families and scary for patients. It's obviously an environment that folks don't expect to leave their house that day and interact with usually. I think a little more so from the air ambulance perspective. These are large distances now that all of a sudden you have to think about, yes, my loved one got into a car accident. That's very scary. They're going to a hospital. That hospital might be 20 minutes away. Now all of a sudden that hospital is 700 kilometers away. Who's looking after my kids? How am I getting there to see that person? Who takes me to that city far across the province? What does that look like? And so we need to really understand what our patients are saying about the care we provide and about how we communicate with our patients. Oftentimes we become sort of a forward voice for what will be the receiving hospital. So people want to know, is my loved one going into trauma surgery right away? Is my loved one going into neurosurgery right away? Is my loved one going into cardiac surgery right away? What does that look like? I'm going to make the trek 300 kilometers from Timmins down to Toronto, or 400 kilometers from Timmins down to Toronto. But when I get there, am I going to be able to see them? Are they going to be in surgery? What does that look like? Where do I go? Toronto's a really big city. It's very dense. How do I drive down there? There's lots of things that come up in people's minds in these moments. And I think we have to appreciate that we provide that communication to them, and we have to understand a little bit about the system. So in our case in Ornge, we do quarterly patient satisfaction surveys, which go out to all of our patients and families who've interacted with us. And we get everything from little bits of information like, hey, we need headphones because those planes are really loud, to big things like how do we communicate expectations on cardiac surgery when we get down there. And so I think we use that information. We drive that as part of our continuing medical education as well for our staff to make sure that that patient feedback is being brought to our clinicians so they hear what the paramedics are saying or what the patients are saying about their care as well.
Does anyone want to expand a little bit more on the survey questions? Because we've been receiving various questions about your EMS client experience survey. So there is one question coming from Qatar, I believe. Do you conduct this quality to all of your EMS clients? If yes, how do you conduct it and use it for meeting accreditation requirements and improvement in these services? So basically the question about your client satisfaction or patient satisfaction surveys.
Yeah, I can speak a little more to it. So we have decals in the back of the ambulance with a QR code. It's on our website, and we have cards as well that we can hand to our patients and the families. And there's a full survey on that. And part of it The survey is, would you like to be contacted for further information? Or do you want to join our patient advisory committee? So that way, when we are doing changes, we'll incorporate them and say, what do you think of this? Does this work for you? Does it not? And how can we make it best for everyone? Because everyone gets a say.
Do you mind if we stay for maybe 5 or 10 minutes longer? Because we received many questions, countries. But correct me if I'm wrong. Maybe we're using this in Alberta too, or in Ontario.
So Alberta, none that I know of. It's Alberta Health Services, which is the whole kind of province. We're contracted through them in Lethbridge, but none hospital-based that I know of.
Okay. Okay. So the question is for you, Martin. How do you coordinate your activities with SMORE and PIT system organized by hospitals themselves?
Yes, it's the organization of the total EMS system in Belgium is the federal government that does that thing. So they have a programmation of the country with that they say, okay, we divide the regions of the country into different regions, and we have to get by a victim within 15 minutes 90% of the cases of an emergency. So in that way they determine where ambulances must be placed. But when there's at a place where an ambulance has to be placed, and there's also in a hospital, they try to get an arrangement with the hospital to place a MUG or a PIT ambulance. So that's an upgraded resources with an emergency nurse or an emergency on board. So that's not what we can deliver from the fire zones or the private ambulance services who are also connected in the EMS services. They cannot provide such an upgraded resource. The government don't want that we organize these things, because they think that an emergency nurse has to be for 80% of the job time on the floor on an emergency department. So it's not possible to have an emergency nurse. We have emergency nurses in-house in the fire zones, but they cannot act as an emergency nurse on a PIT when they are going with our ambulance. That's the law in Belgium that makes it like this.
All the neonatology teams are hospital based, and so they run out of our pediatric tertiary care centers. And so they're integrated through our land ambulance and our Orange dispatch centers. So similar to anything else from an interfacility, they have a request for service. That's all run through Orange or run through the local dispatch center, depending on the distance. So if they need an airplane or a helicopter to get them to that patient, that comes through us to provide that asset to get them there. If it's a short distance within the city or within a drivable distance, they work with one of those 22 land ambulance dispatch centers to get an ambulance resource to drive them to those locations. But outside of the pediatric teams, who are wonderful and are good partners with us in Ontario, we provide, and land ambulance is provided all by municipal and provincial government, not by hospital.
Another series of questions that we received here are about dispatch. So one of the questions is, it goes a little bit technical, but I will still read out this question. So I think coming from the Middle East as well. Predetermined attendance, similar to fire services. Does your EMS use a dispatch code system in allocating ambulances units based on the initial info received by EMS dispatch? No, not very clear.
I'm not exactly sure what they're looking.
Okay, maybe let's move on. If you could maybe precise your questions, we will ask it again a little bit later in a few minutes. All right. How does Orange addresses challenges related to staff and retention in training of critical care paramedics in a province as large and diverse as Ontario?
Excellent question. So one of the challenges that we face, obviously, with the difference, obviously, in the geography that I described at the beginning, with very rural and remote communities in Northern Ontario and very dense urban in Southern Ontario, that results in often advanced care paramedics mostly working in the southern area of the province as opposed to the northern area of the province. And our recruitment model it has a multiple sort of pronged approach, but one of the main and principal pipelines for coming into Ornge is being an advanced care paramedic in Ontario. That's a big challenge, obviously, because most of our advanced care paramedics live in Southern Ontario. And so for them, that means moving their families, moving their lives and moving to Northern Ontario. And that becomes a challenge for folks and becomes a challenge for our recruitment efforts. And when we do recruit, it becomes a challenge for retention. Often we can find young folks who may want to move up to northern communities, but then when they start having families or thinking about marriage and those types of things, moving back down to family networks and moving back down to their local communities where they have support is a challenge. What we've been doing at Ornge is myself and another research partner of mine at Ornge have partnered with the Northern Ontario School of Medicine, and we've been doing some work with them around recruitment and retention and trying to understand that specifically in rural and remote communities in Canada. So far, our work has done a literature review, and we've also done a survey of paramedics across the country to talk about drivers and barriers for working in rural and remote communities in Canada. We are sort of at the final stages of that manuscript, so hopefully that'll be out soon for folks to learn. But the short answer to that is no surprise, really, that you have to look at supports in those communities so that when you do want to start a family, you have those support networks that exist, childcare, daycare. For many healthcare workers, these are 12-hour shifts. And so trying to find a daycare that'll take your child at 6 a.m. and keep them until 8 o'clock at night, 9 o'clock at night is a very difficult thing. And honestly, who wants to leave their kid for 14 hours? So those are big challenges that we have to overcome. And when people's families are far away, how do you make sure there's a support network there for them? We're also looking at how do we train Northern Ontario paramedics who already have their lives and their roots established in those communities, and overcoming the barrier of being primary care paramedics to get them advanced care training so that they can go work into critical care. So looking at decreasing the barriers to access to education, which is a huge barrier for Northern residents, Indigenous peoples already as a major challenge. So Ornge is looking to partner with NOSM to try to remove some of those barriers in those spaces so that we can have actual Northern residents working in the North and caring for their communities. We know that job satisfaction is much higher from the research as well when people are caring for their own community or their own identified community. And so trying to improve that and have people caring for patients in the North who are from the North, we think is part of that answer. But certainly a big challenge, and I wish we could say we knew all the answers, but we certainly don't. But we're starting to try to understand it a little bit better.
Fantastic. So I will ask the last question, and it's kind of symbolic. We started with the patients, and let's with the patient, and let's finish with the patient. So we received a question here from St. Lucia. If I think I know the person who had that question. So a question for Heather that could be addressed to any panelist here. How can any organization begin to involve patient in their care, even when there are uncertainties?
Good question. It's also very scary to involve patients and families, but it starts with, it can be, if it's in a hospital unit based, you can go and talk to patients right in the bed. If you're in EMS, similar to what Michael and Christopher spoke to, put the call out to the community and just say, let's work together. I know our own CEO, Leslie Thompson, when she did her great work at Kingston, went out to communities and found out what the problems were to incorporate it and really shift the culture within the organization. So we are as well here at Accreditation Canada and Health Standards happy to help have conversations on how to do that as well. So feel free to reach out.
Excellent. Well, I think this is the end of our session today. Thank you very much on behalf of Accreditation Canada. I'd like to thank all the panelists, all the attendees. Obviously, please keep following us. Stay tuned. As I said, we will be preparing various webinars. One of them will be in June, and even I believe 2 webinars we're preparing right now that will be released in June. There will be webinars in the fall, so stay tuned. Contact me, connect with me, send me a message if you're in Stockholm in early June as well. Please fill out the survey at the end of the webinar and stay tuned. Thanks a lot. Bye.
You.